we'll go ahead and proceed. Looks like you guys got everything. You understood everything. So maybe I'm going to ask you guys some questions then. And so we're going to start with class 3 cavities. And so in between the lecture, I would like you guys to unmute yourself and answer a few things. So I want it to be a little bit more interactive versus just me talking. So I want to know from one of you guys, what is...
It doesn't involve the incisal edge.
Very good. So it doesn't involve the incisal edge. And if in case we are doing a class 3, like this one, where there is a decay and it is not involving an incisal edge, and we go in and we start drilling. And you sometimes cannot predict, and we go closer to the incisal edge and we've removed dentine, then in that case, what happens? Can somebody unmute and tell me what does that become?
Does that be like the root would be exposed and then possible RCT treatment?
No. I mean, it starts going further incisally.
Oh, okay.
And it starts involving the incisal edge. The decay starts involving the incisal edge. Then in that case, what would the cavity be called? Would it be called class 2, class 3, class 4?
4.
Class 4.
4.
Class 4?
Class.
Okay. All right, good. So, you sometimes you are trying to do a class 3, but it changes into a class 4. You cannot predict those things. Dentistry is fun in that manner that we cannot predict everything. So right here is a class 3 composite prep. It is an ideal prep. It's on typodont and it looks nice and everything. Clinically, a lot of times things don't go in this manner. A lot of times when we are doing composite preps, we just remove the decay. We are not going to go, okay, I have to go axially 0.5 millimeters in dentine. Or I have to go this way. Or, oh, since I have to place a bevel, let me do this, let me do that. No, nothing. Wherever there is caries, you remove the caries and you are done. So it's as simple as that clinically when we are doing it. But when we are doing it in typodont, we're going to do an ideal prep. So that's the difference. And right there, that little bit of dark white thing, what do you guys think that is? Can somebody tell me? In the preparation, if you see there is some kind of a material, dark white, can somebody tell me what that is in the prep?
Glass, I'm on it, GI.
It's Vitrobond. So a lot of times in class 3 cavities, we use Vitrobond. It's very simple because glass ionomer, sometimes we have to use a lot more. And so I really like using Vitrobond where it's just you mix, there's 2 tubes, you just mix one dot of each and then just carry it and then just place little bit, tiny bit at the deepest end of the prep. So if your axial prep is little bit deeper than 1 millimeter in the dentine, then you just place Vitrobond. So I'm going to talk a little bit about, when I graduated and everything, I was always confused about when should I use Dical, when should I use base, and when should I use like a Vitrobond. So do you guys want me to explain you when to use when?
Mm-hmm.
Yes. Okay. So let's assume this prep went more deep. But it hasn't hit the pulp yet. It's almost there. You can see the pulpal tissue. And sometimes maybe a tiny bit exposure is there. But it's like it's not bleeding. Nothing is there. In that case, you use Dical, which is calcium hydroxide. And you just get little bit and just place it in that spot. And then and then on top of that, you put a glass animal filling, and then you put a composite filling. So that's when it's deep. And then when it's pretty deep, you let the patient know when you're placing Decal that it's a deep filling and you might need a root canal. And I cannot tell you when you might need a root canal. It might be tomorrow or it might be 10 years down the road. A lot of times we cannot predict. So, and then you can tell them if you have symptoms, things like that happen, then you might need it. So Decal is only when it's pretty deep, the decay, and you're almost to the pulp. And the little bit of pulp corn is showing. So just place Decal, but there is not excessive bleeding or anything of that sort.
Dr. Go, can I say something? What she's talking about, and you will see, it's called blushing. It's when in the dentin you see pink. Like, you know, when you blush, when somebody says something that makes you fluster and your cheeks get pink, that's what you see in the tooth.
Thank you, doctor.
That was it, doctor.
Yeah, thank you. Thank you. You explained it very well.
Can you repeat that, please? Dr.
What I said?
Yes, please.
Okay. What she is talking about is called blushing. She says that the decay goes deep. It may microscopically be touching the pulp, but not that you see bleeding. It is called blushing. It essentially is that the blood is getting into the dentin, but is not coming all the way through. It's blushing just as when you were a kid and you were embarrassed of something, your cheeks blush. So it's the same concept.
Thank you.
Okay, Dr. Gokati, go ahead.
Okay, so you place the Decal, then you can place some glass ionomer, and then go ahead, because now a lot of dentine is exposed. So you want to cover the dentine with glass ionomer, and then place the composite. So dentine is kind of similar to a base in that situation. So you're actually placing Decal, which is for your pinpoint exposure. Which is there or not there. It's kind of a very clinical judgment call. Then you place the base, which is glass ionomer, and then you place composite. Now, in second scenario, where the cavity is deep, but it's not as deep as going close to the pulp. It's little more deep, maybe 2 millimeters deep in the dentine, or 2.5 millimeter, like not too deep that the blushing effect is there or anything. In that case, you can use glass ionomer as a base and then go ahead and proceed with your etching and everything. So after you have prepped, you have to evaluate at that stage whether you are going to place Decal, you're going to place a base, which is like glass ionomer, or you're going to place Vitrobond. So Vitrobond is only in this kind of a situation where the depth is just 1 millimeter deep in dentine. So the normal prep is 0.5. And when the dentine exposure is 0.5, in the after the prep is done, you do not place any base, nothing. Everything is good. You proceed with etching, bonding, and placing the composite. But when it's deeper than that, like 1 millimeter, then you proceed with Vitrobond. So I hope everybody's clear with that and we can proceed further.
Yes.
All right. So we talked about class 4s. Now this is class 4 composite prep. Now if you notice the bevel is a lot in class 4 composites. So in class 3, actually nowadays a lot of schools are teaching not to even place bevel. And if we have to place a bevel, it's going to be a very slight bevel of 0.5 to 1 millimeter. But for class 4s, it's going to be, can somebody tell me how big the bevel should be in class 4 cavities?
1.5 to 2 millimeter.
Oh, wow. Good. Awesome. You guys are all prepared. I'm proud. Okay. So I don't know if I need to go into caries etiology. You guys all know it's plaque, it's poor oral hygiene, dry mouth, all those causes, caries. You just need to just look what's going on in the patient's mouth and why he's having so much cavities. If the patient is having too many cavities in his mouth, be careful to do too much composites. You might switch to glass ionomers at that time. So you guys will talk more in detail about what filling to do when clinically. So for the class 3 diagnosis, on the X-ray, you can see radiographically the decay has gone a little bit beyond the DEJ. And that's when it's an ideal situation and you go ahead and do the filling. Now, when the decay is just in enamel, at that time, it all depends upon patient. So some patients, if you see their mouth has a lot of decay, you can go ahead and start drilling and do the filling because it's going to be small at that time. But in few cases, you can just put a watch and put some fluoride varnish on the teeth. So it's a clinical judgment for when it's just in the enamel. There is no apex of the tooth which is involved. And I have actually, I just attached a YouTube video today regarding how to see a class 3 cavity on the X-ray. It shows the decay pretty nicely with the color change under marginal ridge on the X-rays, and like how you can see through your mirror. Just please watch that radiograph video. That's pretty good. And sometimes clinically you can see there is decay under the marginal ridge because there is blackish color, and you can kind of make a clinical call on that if the decay is happening. So you go ahead and then make a call and start the prep. So when do you go facial or lingual, or how do you make a decision for that? Can anybody tell me, when you're approaching a class 3 cavity prep, do you always start facially? Do you always start lingually? Or it depends upon where the decay is?
Depends on where the decay is.
Okay, good. Yeah, so it all depends upon that. But if you go facially, or if you have to start facially, please talk to the patient before, because you have to let them know that it's in the front, and the shade matching, all those things have to be more of consideration, and don't make the patient have very high expectations. So it's better for the patient to have low expectations, and then you obviously meet them and give more to them, rather than telling them I can do a perfect job and then not being able to do it. So now when we are doing a class 3 preparation, there are lots of things we have to keep in mind. I'm going to go through this pretty fast because you guys are not going to do it, but I'm going to just ask a few questions just to see if you guys have understood the material. So when you're doing a class 3 prep, after it's completed, does it look like a square, a rectangle, or a concave? How does it look like? Can somebody let me know? Like the shape of the...
It's rectangular, right?
Yes. yes, yes.
Oh,
Yes,
I don't. I thought it was concave.
can everybody
I don't understand why it's rectangular. I know that's the right answer, but
if you go back,
uh-huh.
if you watch the YouTube of Dr. Stevenson, you'll see he has explained it pretty well. It's rectangular. So, first question I'll ask you is, where does the decay start? Does it start on the contact area, below the contact, or
Below.
above the contact? Below the contact, right? So we have to involve the contact below the contact area. And then when the decay, what happens with the decay is it starts below the contact area and then it proceeds towards the contact area. So that's why it becomes rectangular in shape, because you start drilling from the below the contact and then you go a little bit in the contact area. So that's how it becomes rectangular in shape.
Mhm.
Does that explain?
Yes.
And then if you watch the YouTube, which is in my presentation, it explains it pretty well too.
Okay.
Okay. So, and then when you're doing composites, everything has to be rounded corners.
Yeah, that's why it's like concave is like inside.
Yes, it's inside.
That was confusing because
Yes. So that's why I wanted to just trick it a little bit. But yes, it's inside where it's concave, but the shape is rectangular.
yeah.
So you have to make sure what you're asking.
That was the question that was in the test, right? Where it
Yes.
said that, and I got it wrong because I thought the same thing.
See, so we should have
you did
half point.
that Samantha had. Yeah.
Yeah.
Same.
So yeah, it looks like. So you guys did the questions then.
Yeah, I did.
Good.
Well,
good.
now we do. Well, I mean, once I saw the answer, I was like, oh, okay.
So this is an ideal situation. This is what you will get in the typodon. But clinically, it just depends upon where the caries is, and that's where you remove the decay. So these are all the extensions you have to follow, and just make sure the incisal and the gingival walls are parallel to each other. So you have to make sure they are parallel. So right here is the ideal situation, ideal prep, how it should look. And the walls form 90-degree angle with cavo surface. So that's a question in the test too. So just remember, it's 90 degrees, it's not 45 degree or any other angle that it forms. So rounded internal line angles. And then if suppose we go into the incisal edge, then it changes into a class 4. Now, the most important thing in a composite is why are we able to just drill the caries and go ahead and do a composite filling is because all the retention is through bonding. And that is the reason we do not need to put any retentive grooves or any other thing beside the bonding does all the work for you. And that's why precision is very critical in case of composite fillings. So now, how do we get retention? So can somebody tell me why are we placing bevel? What is the logic of bevel? I know in class 3, we don't place bevels, but like class 4, we are placing bevels. So why are we placing the bevel?
So the composite can blend.
Yes, for blending. Yes, that is one reason. And what is the second reason we are trying to do when we are beveling? Remember one thing that mainly the bonding is happening at the enamel. So dentine does not really bond with the composite. The bonding is happening at the enamel. And when we bevel, we are increasing the surface area of the enamel. And what happens when we increase the surface area? We are going to increase the bonding. So that is very critical why we are doing the beveling. And in class 4, that's why we bevel a lot more, because the forces are going to be way stronger. The occlusal forces on that filling are going to be way stronger. So that's why we want a better retention in that case. So is everybody clear why we are beveling? Because this question is very, very important. Why we are beveling the enamel. So once you have bevels and everything, you want your walls to be smooth, and don't extend the prep just for the purpose that, oh, you have to place a bevel. No, if there is no decay, everything looks good, please do not break the contact. Now, the bevel in class 3 is 0.5 to 1 millimeter wide. So first thing you're going to place is a rubber dam. You want to make sure there's no leaks. It's inverted, it's centered on the face. And after you're done, you want to make sure there is no soft tissue damage and no damage to the adjacent tooth. So before you choose any composite patient, you have to always check on their gums, how the gums are. If they're very inflamed, red, you want to tell the patient that first we have to do your cleaning. The composite filling is not going to work in this case. And so you go ahead, do the cleaning, wait for 15 to 20 days or so, let the healing happen, and then you should proceed with the composite fillings. So I think we covered this pretty much about pulpal protection, what all to place. So we are going to go ahead, and you have to make sure the contours follow teeth. You want to flush. There should be no voids or any excess. You want to remove any flush or anything. You want to check the occlusion, and you want to check the contact is established with the floss. Make sure there's no damages, and the surface is polished. So if there is a void in the composite, what do you guys do? Can anybody tell me? Do you drill?
Drill where the board is and etch it and prime and bond it.
Yeah, bond and then put some composite there. Yeah, good. So you just remove that little area and then just proceed as if you're doing a composite filling. Good. So right here, we're going to do a class 3 restoration. There's this one is facial, so it's pretty easy to do. When you are going to do a class 3 lingually, the challenging part is learning the technique, how to do it in direct vision. So that just needs practice, and we'll do some tomorrow, so that will help you guys. Is there any questions you guys have till this point? Please ask me.
Can you answer one of the questions of on the quiz or not yet?
What do you mean?
Because it's due on September 19 and I already did it and I have a question.
Oh, you have a question you didn't understand?
Yeah.
Yeah, go ahead, ask me.
Okay, so number 6 is say what is the correct order? It's Yeah, and when I say bond prime, whatever, and I put number 4 because it said after you prime and bond, you light cure. Correct? Len, I got that wrong. And your answer was like you prime and bond, you could composite, then light cure.
Actually, you are right. You are right. Very good. You are right. After you bond, you have to use the light. So great job. The answer is number 4. You
Yeah.
are right.
Okay, cool.
Thank you.
You're welcome.
Yeah. All right. Anything else you found which was not correct? Or you felt, no, seriously, I'm a human being. So
Yeah.
totally. I mean, that's great that you got it and you asked. Proud of you. So we're going to go over the order once we are doing the restoration. So once the restoration is done, then first we're going to place a rubber dam. So there is a correct order. You have to pick one of them. So then after that, you put mylar and the wedge. Now, putting the mylar and the wedge is sometimes tricky. In a tripodont, it's different because there is no gum. There is no bleeding. But in a patient, you have to be very careful. When you're putting the mylar, just go slowly. And sometimes it's too tight a contact. So you want to separate very gently with a plastic instrument, the other tooth, and then go ahead and put the mylar. And then the wedge. And the wedge, you can try the Garrison one, different sizes. Start with the smaller one. Or you can see the space and then you can guess with that what size of wedge to use in that space. So after that, you etch. So I've been to few seminars and a lot of seminars, they are saying that try to etch only the enamel. Try not to go in the dentine. And I agree with it because, you know, there's not much bonding which is going to happen in dentine. When you're applying the etch, I'm going to show you a way how to apply etch, that first you etch the enamel and then you put a little bit in the dentine. So you're etching enamel for longer time than dentine. And that is going to help you, with getting more etching happening in the enamel. So I want to ask you guys, so after you have etched the tooth, how long do you etch the tooth for? Can anybody answer it? I don't want. How long do you etch? How long do you etch the tooth?
15 seconds.
15 seconds. And then after that, what do?
You air dry it, you rinse it.
Rinse it with water. So, you know, sometimes I've seen some of my assistants, they just like quickly rinse it. You want to rinse it off for a little bit.
Till it's chalky, right?
So that is that I'm getting to that.
Oh,
So you want to rinse with, see, imagine if you got an acid on your face or anything, then you need to rinse with water nicely. People just rush and they feel like, oh, the acid is removed, it's done. No, you want to rinse it for like nice 10 to 15 seconds. And then you want to air dry it. Now, this is the most critical part. Can anybody tell me how much do you want to air dry it? How much do you want to air dry when you have done the etch is removed? So you want to air dry it to an extent where there is no pooling of water, but you don't want it to be chalky. So I know these videos show that the slides have chalky, but the chalky is not the right answer. It needs to be moist, glistening with no visible pooling of water. Okay, so because if you make it chalky, you are dehydrating the dentine, and then the patient is going to have sensitivity. And so do not dehydrate it. So no over drying the dentine. Is that clear? So then,
Class 3 and 4?
what did you say?
It's only for class 3 and 4.
No, I think it is for every composite.
That's confusing because the other question would be, they would say, it would be white and chalky.
Which question says that? Or you,
Yeah.
like previously what you have learned? I totally agree with you. And it is a very confusing thing. Nowadays, every seminar I have been to, I would say I would like an input from Dr. Supadi and Dr. Jumana. What do they think should be the right answer? Because now they are really saying it shouldn't be chalky and white. It shouldn't be, you should not air dry it too much.
Because that's what we learn, in this class, that is white and chalky. So this is the first that we're learning. Yeah, so what's the other doctor think?
Yeah, are they there?
She's
I'm talking. I'm trying to. Okay, that's why they call it practicing dentistry, because at one time it was chalky. When I went to school, it was like what Dr. Gogati was saying. We etched for longer, and you're going to see that pedo teeth etch for a different time, but it was etch, dry, rinse, and dry. And because dentistry has progressed, you never dehydrate the tooth. You cause higher post-operative sensitivity. Right now, it's exactly what Dr. Gokati says. You rinse and then you dry to a certain extent that you still see the dentin is still moist, if you understand. You never dry to make it chalky.
So my question to you, doctor, is that in the slideshows, it says white chalky. Though now they have totally said that is not the right approach.
Correct.
So now the students are confused, I understand, and I want to tell them the right thing. But when they have to answer in a test, because we know clinically and in a test, things are different. So what should they answer in the test?
They should not write that it's chalky.
They should not.
And even if you do and they mark you wrong, you have documentation as of 2020 that is no longer the answer. It's just like with pre-medication. At one time, there were certain conditions that we pre-medicated. You have to keep on top of it because it's completely different nowadays. I would not write dry to chalky because that is the wrong answer.
And I agree with her. So I think it should be that it should be moist with no visible pooling of water.
Yeah, exactly. Yeah, no visible pooling of water is
okay. So should we go further? Now with the bond. So that's another thing I also learned is that when you're putting prime and bond, make sure you, with the micro brush, you put the prime and the bond. Now, whether you are using one step or you're using two step, doesn't matter. But you have to apply primer nicely. That's why at one stage they taught us apply primer 2 or 3 times because, we would get lazy and we would just apply once quick and then be done. So you want to apply for maybe 20 seconds or so, prime and bond. You can see what system you want to use. Any system is fine. You can use separate bottles of prime and bond. I have been using them from last 15 years. I've used the 2-step system and now I switched to 1 step with Voco. With the two-step, remember the prime and bond, where they come in bottles. You have to make sure once you dispense the primer, first important thing is you should not dispense the primer and bond before you're going to do primer and bond. Not like how the assistant dispenses before even I have started prepping the tooth. The primer and bond is already there and they put like a cotton on top of it and they're like, nothing is going to happen to the primer and bond. No, it evaporates and the composition changes of the primer and bond. So you have to dispense the primer and bond at that very time when you're going to, after you etch, you dispense primer and bond and then you place the primer and bond. With Voco, it comes in a single pieces. And so you press the primer into the bond. So that's why I like it, that there is no evaporation. There's no chance of evaporation. And but any system is fine. So just apply primer and bond. And after bond, you air thin the primer and bond. And I can show you tomorrow how I air thin it, that spreading of that primer and bond needs to stop. So you have to clinically see it. And once it's stopped, then you do not air thin it. And it's a technique where you go from little far away and air thin it. So I'll show you guys tomorrow how to do it. And then you light cure it for 10 seconds. And then you start placing composite. So with composite, I place flowable first most of the time in my preparations. And I like it because I feel like it gives a nice seal to my preps. It depends upon every doctor to doctor what they want to do, but I apply a little flowable and then I apply packable composite, and you match the shade and then proceed further. I also use the micro brush with the bond and apply on it. Now, when I'm using a Voco, which is prime and bond mixed, my assistant has bond bottles separate, and she will pour the bond a little bit on a separate area, and then I will dip my micro brush into that, and I will use it. And it is very, very helpful. And it doesn't change the composition of composite. So once you have done the composite filling, everything is looking good. You start taking out the wedge and the mylar strip slowly, carefully. And after you've cured all the composite, I don't know why. In this, they're saying you just use a mylar strip to kind of help you contour it. And then you cure the composite and you are all done. And then make sure your contacts are good. The flush, you want to remove.
Question, doctor.
Yes.
Even though you have a liner or a base, do you still put flowable?
Yes. So you see, the liner or the base is not replacing my flowable. Remember why I am placing the liner. It's because
I know.
the decay is deeper, right? So I am placing to protect that pulp. See, I am placing that liner or the base to protect the pulp so I don't have that sensitivity issue. So once I have placed, now my prep is ideal. It's 0.5 millimeters from in the dentine, or maybe a little bit deeper. You know, what I'm saying is that at that point, I place little bit of the flowable along all the edges of the tooth. And so some doctors, how they do it, they place flowable and they cure it. I place flowable and then I place the bulk composite and then use the micro brush little bit and kind of press it in that area. So I feel like the flowable kind of helps to go into those little voids kind of thing. So it's been working for me so far. That's all I can say. But there is nothing right or wrong. You can go either way. If you don't want to do flowable, just go ahead and put the bulk.
So the flowable is just for to avoid voids.
Yeah, and it goes into the proximal areas pretty well. Like it will go into the gingival floor and all those areas pretty well. With the bulk, it's sometimes harder to push it in every area. And that's why I feel like the flowable flows well. And then when you push the bulk, all the areas are are covered pretty well. And I'll do it tomorrow, and then you guys can see how I do it. And I use micro brush all the time with the bond that I have to use, because otherwise just with an instrument, I feel like it's sticking too much. And even if I put the bond on the instrument, somehow I feel like with the micro brush, I'm able to shape it or, contour it a little better. So, and then you go ahead and, you can use the finishing strips, or you can use all the finishing burrs, which are there in your kit. So that's for class 3. Do you guys have any questions you want to ask me? No questions? So I can ask you a question then? All right, so let me ask you, the gingival clearance from adjacent tooth when doing a class 3 preparation should be 0.2, 0.7, or 0.5? Can anybody answer that? Okay, so this is in an ideal prep, the clearance from the adjacent tooth has to be 0.5 millimeters. That's what you want. Now, let me ask you one more question. The internal line angles of class 3 preparation should not be rounded. Is that a true or a false?
False.
Good. Now, one last question. The axial wall during an ideal class 3 preparation should be 0.5 millimeter in dentine, not in dentine at all, 1 millimeter in dentine. What do you think?
0.5 dentine.
0.5. Very good. I think you guys got it. So now we're going to go to class 4 restorations. So class 4 restoration mostly happen when a patient falls or chips the tooth, and they come to us and they're like, okay, can you fix this? Sometimes it's due to decay also. And in this, the most important and critical part is picking up the shade and setting up the right expectations for the patient, and telling the patient that, this is more of an aesthetic filling, so please not to chew hard foods. You want to use the adjacent tooth to duplicate the tooth you are making. So if you see like there are some nicks and stuff in the adjacent tooth, try to get those in the anatomy, and you don't want to make like a very ideal prep, then it might look fake. So, and then you want to overfill it and then kind of shape it. And make sure in either class 3, class 2, class 4, any prep, occlusion is the key. So make sure you check occlusion always. Occlusion and contact. Don't forget those 2 points. Those have to be checked every time you do a filling. So right here, this is a full thickness bevel. We talked about how thick it has to be, 1.5 to 2 millimeters. And this is a little more wavy kind of a bevel. And in this one, we are increasing, making it more aesthetic bevel, starburst bevel. So the bevel is very, very critical in class 4. So make sure you do that. We talked about Decal. We talked about etch. Now here it says frosted enamel surface. So I don't know. I don't think it should be frosted. Prime and bond, that's critical. Technique sensitive. Now this, I want to talk a little bit about, suppose you have done your filling, your prep, and now the gum has started to bleed. What do you do in that situation? Like it's little bleeding, but you don't, you're like, I don't know, I think I can proceed with composite. So let me tell you one thing. If there is bleeding, you do not want bleeding when there is, you're going to do composite. So use some ferrous sulfate to stop the bleeding. And then if it has stopped, then go ahead and proceed. But you want to make sure that the ferrous sulfate is not in your prep. So you want to make sure you rinse it pretty well. So even if you, few times what I've encountered is I did etch and I did prime and bond. And after the bond, the gum started bleeding. And I'm like, oh man, what do I do? So at that time, you use the ferrous sulfate, you do everything, and you don't have to etch it again, but you have to rinse the tooth properly, dry it, like how we talked about, and then you have to prime and bond again. So just remember that. And then if you cannot achieve moisture control, then go ahead and proceed with glass ionomer. We keep glass ionomers with us all the time. So whenever we have a problem and we cannot place a good composite, we switch to glass ionomers. So that's composite. And you can do different shades. So, you want to put a transparent shade in the back. So, and then you can proceed, So in my slideshow also, I said transparent. I don't need transparent, I mean translucent shade. So translucent shade is light and dark. So look at the tooth, patient's tooth, and then decide whether you want to use a light transparent or dark. I have used light transparent. I feel like the light transparent is very light and it has given me a lot of gray color in the tooth. So I've not been very happy with that. The dark translucent is, I think, better. So just place the translucent shade in the very back, and then do is think about it as if you're building a tooth. So first, you remember how there is no dentine? So you put a dentine shade, whichever shade you like, A2, A3, whichever shade you think is right. Then you're almost to the enamel area. And so then you put an enamel shade there. And then at the incisal edge, if you want, you can put the translucent shade again. Just don't put too much translucent because translucent shades start giving a little gray look. So the best is that, the regular dentine shades are very forgiving and they're opaque. So they work pretty well. So if you are in a doubt, just use that. Any questions?
Can I add something, Dr. Gogati?
Yeah, please.
Yeah. So as Dr. Gogati was saying, if you have a patient, and older patients, their incisal edges are worn, right? Because they've used them a lot, and you have that transparent look. So that is a good area to use it. And overall, in the years that I have been a dentist and looking at teeth, normally teeth are not one color. Your crowns are one color, more or less, depending on the lab that you use. So definitely, if you have any questions about a shade, take some of the composite. Do not etch the tooth, do not do anything. Put the composite on the tooth and light cure it. It will not stick, right? Because there's no preparation. But you would be able to say, oh, yeah, I picked a good shade, or no, this is too yellow, or no, this is too gray. So it's not like you just pick shades and start your filling. You can practice on the adjacent teeth if the shade that you picked was the correct one. Do you understand what I'm trying to say? Do you have any questions? Like if you're picking an A3 and A2, the A's, if you put it on there and you're, wow, this is too white, you can pop it off and then pick another shade and get as close as possible. That's it.
So I just want to ask them one last question, which I think is critical, is how does composite restoration gain retention? So can somebody tell me? Because you know how amalgam, we have to drill deep. That's how we are getting retention. But in composite, how are we getting retention? This is very, very important to understand. So I just wanted to go, I want somebody to either tell me, like, is it with the beveling, the enamel beveling? Is it with bonding? Is it with both? Is it with retentive groups? What helps the composite restoration to gain retention?
Bonding and enamel.
Yeah, enamel bevel. Yes,
Yes.
and enamel too. That's true because we're okay. Awesome. I think that explains everything. One of my question I have asked about composite is cured in increments of how many seconds? And I have answered it as 20 seconds. But honestly, I feel that it all depends upon the composite light. So if you are asked that question in the test, and if there is a choice of it depends upon whichever light you're using, then answer that. That's what I think. What do you think, Dr. Supati?
I'm sorry, I didn't hear the question. There was a background.
It's about composite is cured in what increments? Like, do you cure it for 10 seconds, 20 seconds, 30 seconds? Or it depends upon the light, the composite light?
It depends on the light.
Yes.
If you look at my video, and I was talking, because of the C factor in the polymerization and the shrinkage, there are some lights that are pulsating. There's others that go, 5-10 seconds. But also the quality of the light. There's some lights that are super, super strong and they just cure. Of course, you want to use a lower setting. So it depends on the light.
Yeah, and make sure you check your lights often.
Right.
Perfect. So I've asked a question in which I didn't give that choice of the light. So that one is 20 seconds. But if there is a choice of any light, then please make sure you answer that. So I think that's about it. I think that, and I wanted to say one more thing about the light is that, a lot of time we are very close to the composite. And if we haven't put a protective covering on the composite gets stuck with on the light, and then its efficiency gets decreased. So make sure you put a cover on the light. So that is important, because then sometimes we are compromising on our work later. So that's about it, Dr. Jumana. If anybody has any questions, please ask me. Thank you. Thank you. Thank you, everybody. I'm looking forward to see you all. Thank you. Good night.
Thank you. Well, first of all, I want to say that normally I wanted to also pull up YouTube videos. Being the class 3 amalgam composites are hardly ever placed anymore. I'm even having difficulty pulling up a class 3 amalgam. With that said, we need to review it, and we also we've already learned how to pack the amalgam. We know that in a amalgam preparation, there are undercuts that we need to pack and address. The contour of the difference from a composite to an amalgam is that when you pack an amalgam, that's why even you cannot use the clear matrix system that you do of a composite, because you need to burnish and pack against that matrix system. You will need a wedge, and you will need a Toffelmeyer and the matrix band around it. Being that the preparation itself, I'm going to go over tomorrow, and I'm not going to go over it today. But the margins, I am not going to be. You do not bevel the enamel. The enamel is going to come out the preparation at 90 degrees. You have to make sure that you overfill, just like we've said so many times. Overfill, pack, and then carve, making sure, and you carve mostly with an Explorer. The Explorer is going to lay against the tooth surface, and it's going to run. The first thing you do is you place it against I'm placing a DO. You're going to place it against the matrix system from the tooth surface, from the incisal all the way down to the gingival. And in doing so, you're going to make that curvature of the distal marginal ridge. Then the anterior teeth have a cupping. It's not flat. It has a cup. Therefore, if you turn the Explorer, it will have that what would we call it? It has that curvature that makes the inside gingival contour of the tooth. And overall, that is it in a nutshell. Like I said, they're not placed very readily due to aesthetics. If you do break the contact, you will see the patient. You will have to tell the patient you are going to see eventually a black line in the interproximal area. That is it, Dr. Germani. Unless people have questions. Should I mute then?
Yes, Dr. Giovanni, it's Tracy. I thought class is starting at 11:30 tomorrow for Group C and D. No, am I wrong? Thank you, doctor. All right. Thank you, Doc. See you guys tomorrow.
Thank you, Doctor.
Dr.
See you tomorrow.
Dr. Kubis, could you stay on? Let everybody leave.
Okay, understand.
Okay.